Hello, everyone. I'm Michael McNutt with Weedy, and welcome to Weedy Spotlight Information Blocking in Focus Practical Strategies to Address Information Blocking Across the Healthcare Ecosystem. It's my pleasure to introduce Weedy's Executive Director, Rob Tennant.
Thank you, Michael. Let me add my welcome. We're very excited about this event. I think folks realize that with the HHS announcement that they're going to step up enforcement of information blocking, I think it's imperative that we all know exactly what information blocking is and how to avoid any uh, enforcement action. But before we jump into the content, I just wanted to run through a few slides. For those that aren't familiar with Weedy, we were formed back in 1991. The this First President Bush had tapped Dr. Lewis Sullivan as the HHS secretary, and he convened the industry, brought stakeholders together to talk about how to make health data exchange more standardized and efficient. And therefore, he commissioned what he called the Working Group for Electronic Data Interchange, and they produced two reports, which were folded into legislation you may have heard of called HIPAA. So we're very excited to be named in that law as an advisor to HHS, and we've performed that role ever since. We have multi-stakeholder membership, including health plans, health plan associations, providers, provider associations. We've got vendors and clearinghouses. We've got all of the standards development organizations. And we also have the government itself. In fact, both ASTPONC and CMS both serve on the Weedy Board of Directors. And we've now expanded to include a number of patient advocacy organizations. So we're very excited about that. If you're interested, reach out to Bill Alder to learn more about being a member here at Weedy. So what do we do? Well, we have two roles. We convene and we advise. So you're part of the convening aspect today, where we bring the industry together to talk about important health IT issues. We develop guidance through our work groups. And we also serve as an advisor. So obviously named in HIPAA, we have a unique relationship with HHS. And in order to develop recommendations for the feds, we have what we call a member position advisory process, where we gather stakeholders together to discuss and review issues and submit recommendations to our board of directors. And as part of that process, we develop comment letters. Um, uh, Ladders serve to educate policymakers. And again, a big part of what we do is give a multi-stakeholder viewpoint on issues directly to policymakers. Next slide. So we're very excited with today's faculty. Really, it's a blue ribbon group of individuals. Chelsea from CHIME, Rebekah from the ADA, Arna from Stedi, Alyssa from Indiana Health Information Exchange, Sasha from the Electronic Health Record Association, and Andrew from AHIMA. And moderating today's program is Jeff from the AMA. I just wanted to let you know about where a lot of Wheaties work is done, and it's done through our volunteer groups. And in fact, the genesis for this program came about from Arna and Rebekah discussing information blocking in our dental sub-work group, which Arna chairs. And we felt it was such an important issue that we wanted to broaden out the discussion. And so that's why we developed the program today. But as you can see, we've got all of the HIPAA transactions, or most of them, covered by a sub-work group, but we've also got things like genomics and acknowledgements, privacy and security, which you'll hear about later. And the No Surprises Act, which is such an important data exchange set of regulations. We've devoted a task group just to discussing that. So if you're interested in getting involved in one of our work groups, sub-work groups, or task groups, again, reach out to us at Weedy. And in fact, Ariana at apool@weedy.org will be happy to sign you up if you're a Weedy member. With that, we'll go to the next slide. So after our welcome here, we're going to jump into the current landscapes and discuss some of the key challenges, and there are plenty when it comes to information blocking. We'll talk about the exceptions, some of the outreach and actionable steps that organizations can take to prepare themselves to ensure that they're not blocking information. We'll have a Q&A and then some final thoughts from the panelists. But I will encourage you, if you go to the next slide, we really love these to be interactive events. And so, for example, you can use the chat feature here in Zoom to make a comment, to raise a question, to raise an issue. Take advantage of having this incredible group of experts on our panel. So ask your questions and again, take advantage of this. As always with Weedy, we record these events, and for your colleagues perhaps that couldn't make the event, we'll send you the recording and the slides, and you're able to share those with your colleagues. So with that, it's my pleasure to turn it over to the moderator, Jeff. And again, thank you, Jeff, for taking on the yeoman's task of trying to wade through all of this material.
Thanks, Rob. Thanks, Michael, and thanks everyone for joining. Like Rob said, I think we do have a good cross-section of folks from organizations that are impacted by the information blocking rules. So we're excited to kind of dig into some of the questions that we put together. I think we have information available about all the panelists. As Rob said, we want to try to make this as interactive as possible. So we will be stopping along the way for questions. So please populate the chat with questions as you think of them, and we will try to incorporate them into our discussion today. So to just kind of jump right into it, I think it would be interesting for folks to kind of talk about their different organizations and where their members or their stakeholders of their organization are kind of currently in terms of the information blocking environment, and what sort of landmines are organizations encountering as they begin to operationalize the information blocking rules. Who'd like to start?
I'll jump in. Rebekah,
Thanks, Rebekah.
With the ADA. So I represent all of our members, about 160,000 or so dentists. And then, of course, try to also represent those who are not our members, another 100,000 dentists or so. One of the places that we struggle with information blocking and what the individual practice provider might know about it is that we are still a cottage industry. I don't love that term, but it's the way we describe it. 1-2 clinicians working with a small team or small staff. We don't have information officers. If there is a tech stack, it may be managed by the vendor. It might be managed by a sort of third party doing a lot of the work for them. So when you start asking about information blocking, how it applies, how they're going to meet the requirements of that, they may not actually know exactly what you're talking about. I think most providers would be able to explain the HIPAA privacy rule more, than information blocking. So we'll get into more of the reasons for that, but as far as what the ADA is doing is really trying to educate our members through webinars, having a fact sheet, and speaking up about the challenges that especially the small provider is facing with these rules.
Yeah, I will step in, and just to echo Rebekah's point, I'm Arna Meyer. I'm with Stedi. I work across both dentistry and medicine, but have been chairing the dental sub work group for a while and been very involved in the dental industry. And Rebekah is correct in that we have an education problem. We have just a lack of understanding of the federal regulations that apply to the industry. I think there's a willingness to want to be able to do this, but we just don't have the infrastructure. Our technology vendors have traditionally not had to participate in a lot of the federal mandates and programs because of the way that our funding streams come into dentistry. We're a predominantly privately insured market. We don't have much participation in those federal programs, Medicare, Medicaid, even military programs. And as a result, we're sort of lagging quite substantially in our adherence to these rules and regulations. And the big pitfall is our vendors just aren't aware of their rights and responsibilities as part of participating in the healthcare exchange as well.
I'm happy to go next. I'm Chelsea Arnone. I represent CHIME, the College of Healthcare Information Management Executives. So our membership is largely CIOs, CISOs, the C-suite health tech people from, and others that are, director level and above at hospitals and healthcare systems. But we also do have LTPAC behavioral health providers as well, who sort of have a different perspective. So we have sort of the gamut from the rural health hospitals, the critical access, to your massive integrated delivery systems.
I can certainly go next with Chelsea. I'm at the American Health Information Management Association, or AHIMA. We represent over 40,000 health information professionals, both from a membership perspective and a credentialing perspective. The health information professional works with CIOs like Chelsea and across both the provider, payer, and technology landscape. They kind of sit at an interesting spot within a lot of the health information exchange conversations. They're kind of advocating both for the provider and sometimes the payer, and also sometimes the patient in the conversation and handoffs as it relates to the exchange of health information. If you're unfamiliar with who exactly an HI professional may be, if you've ever called to get your record, you've most likely talked to one of our members or an HI professional to get access to that information. As we've worked over, it's hard to think it's been 5 years since we've started to get ready for the compliance space as it relates to information blocking. What many of my colleagues on here have talked about are also similar challenges that we face within the health information profession, being able to get ready for and comply with information blocking. But in addition, I think there is just outgoing and ongoing questions that relate to understanding, what exactly is information blocking, and how exactly will those within the federal space view what may be an information blocking complaint, and how is that documented, and how does that impact the way that the space is going to function once those complaints and then ultimately actions are taken from HHS. And so as we work, and I'm sure we'll talk more today, it's really going to be about getting clarity as we move forward into this investigation and penalty phase.
Happy to introduce myself next. I'm Sasha Termat. I work at Epic, but I'm here today representing the Electronic Health Records Association, or EHRA. At EHRA, I am a co-chair of their Information Blocking Compliance Task Force. So like many of you, I've been working for many years now to try to understand as best as we can the regulations. EHRA members are the vast majority of certified health information technology developers. So that makes us one of the important stakeholders of these regulations and one of the regulated actors. I think it also contributes to maybe two of the landmines that we've seen. One, and I think this echoes what the other panelists have said, is simply the complexity. This is a very complicated set of requirements and exceptions to those requirements. And having talked about it with other stakeholders for many years, I think there's still much to be understood. The second challenge that I think we face as electronic health records developers is what I'll call the meaningful use expectation, that ONC regulations and things that ONC or ASTP publish are just going to be handled by your EHR vendor. That was maybe a conception that came out of the meaningful use era and the close relationship between certification requirements and the meaningful use objectives. But it is not the case in the information blocking world, and there is not that close relationship between what's in certification and the obligations of each of the regulated stakeholders. And I think understanding that has also proven one of our challenges.
I can speak next. I'm Elisa Kewen. I'm with the Indiana Health Information Exchange. And as an HIE, we have this tension between, the law saying that we must provide certain information and then what our data governance says. We are a collaborative of members of the HIE, and we act as a business associate. And we are only permitted to share information in certain ways based on that data governance. And we have procedures for getting approval at any time we need to change or add to those acceptable uses of the data. And so if there's a request that would require a process we don't have or a use case that has not been approved, it adds that complication. If we were to receive, for example, a HIPAA authorization signed by the patient to say, release my information to this entity who is not your member, we don't have a current workflow for really, reviewing that authorization request and then releasing information because there's no use case. We've never had that particular scenario approved by our members. So it's really a matter of, we'll have to take things as they come, I think, and determine the best approach that works with our membership.
So taking off my moderator hat for a quick second and just answering kind of from the physician perspective, I will just kind of echo everything that folks have already spoken about in terms of the complexity and the education problem and kind of the expectations of small physician practices maybe that are reliant on a vendor or a consultant for a lot of their IT services. That they would necessarily be able to kind of manage a lot of the work related to information blocking. So I think that's something that a lot of physician practices are still kind of struggling with in the understanding. So to kind of jump to the next subject, one of the big issues that is out there now, and I think has been reinforced by the ASTP over several times over the last couple of months, kind of relates to TEFCA and the work of QHINs to encourage information sharing. So do folks want to kind of talk about maybe some of the expectations that maybe exist now around TEFCA and information sharing in the kind of information blocking space and how that all kind of works together?
Hi, Jeff, I'm happy to take some of this given some of our members, the early adopters of TEFCA, the larger hospitals and health systems. And I did ping our policy folks, like the CIOs that advise us, and I had some interesting things I learned. Overall, TEFCA or participation has not really changed how they approach information blocking, because while there is sort of a TEFCA manner exception, that's not really why they're joining. They're joining to just share data, and it's because it's the right thing to do or their organizational decision. But one interesting thing a rural member shared with us, who's a mid-sized hospital, that they really had found it to be they were happily surprised that joining TEFCA, in the first 2 months, they went live like mid-September, and they grew their trading partners from 1,500 to 2,200 in 2 months. And most of them were individual or small, like individual providers or small practices. So they also did their monthly exchange volume jumped from 600 to over 800,000 records. So I think that their experience has been good. For the rest of the folks that have already been part of their HIE and they have a great HIE, then it's not changing a ton for them. But again, with the exception, it was meant to encourage participation, but it's not really being applied because both the actor and the requester must be participants. And so I don't think they're looking at it from like oh, we're part of TEFCA, so we don't need to worry about information blocking. We're just sharing. I think it's a little bit more than that, but it's just added some additional questions regarding treatment, operations, payment with other folks being sub-participants and kind of muddying the waters a little bit for our vendor friends that are, making sure that our folks are getting the information to their patients. But they overall support the nationwide they're excited about it, but we're not seeing it there yet.
Chelsea, I agree. I think we've had a similar perspective in EHRA. We're very optimistic and excited about the opportunities that the Trusted Exchange Framework offers, and many members are working with their clients to onboard. I think we would love to see a world where doing something proactive, like joining TEFCA, alleviates some of the uncertainty of all the information blocking complexity. That's not the case today, but I think that would be something that would provide a lot of incentive to participate in TEFCA and really engage that way. And as it becomes the single on-ramp to so many different types of interoperability, I think it will hopefully replace a lot of the other work that people have had to do historically to exchange with a lot of different parties. But at this point in time, I think it hasn't quite hit that level of momentum to take over all of the exchange or any of the information blocking compliance work that groups are doing.
Yeah, I'll speak a little bit from the dental experience. We were excited. We saw, I think, about 13 states either intend to include dentists as required to join their state HIE or did actually require that. Unfortunately, as those sort of rolled out, the technology barrier where our systems weren't able to actually connect to the state HIE became just register with your email, at least you'll have an account. And so you may have a profile, but then meaningful usage of the HIEs, and then the ability to go up through the QHINs and TEFCA. I mean, I don't think that there is any really meaningful usage. And just anecdotally, of the very few providers that I've heard, hey, yeah, I actually log in and look, it's because they're going in through the portal. It's not integrated into their workflow or integrated to their systems. So when we talk about how information blocking isn't impacted in our world, it's not. I think in the future it would be great if it was. But I think fundamentally we, at least in the dental industry, haven't even decided if information blocking should exist as a concept. Ownership of records is a hot topic right now, and I don't think there's agreement.
Yeah, and there's also we've got our core set of data interoperability, which there's still gaps in what information is being moved, and so for dentists, getting clinical information that may be relevant to coordinating care based on cancer or pregnancy status or diabetes is fantastic, but transmitting that information around oral health is lacking because we don't actually have that infrastructure yet. And so because of that, I think that's another reason why adoption is kind of low, is because there's a lack of representation of tertiary healthcare industries. And I know there's development in place, like the Oral Health Interoperability Alliance is really doing good work there. And we're making strides to include more body parts, for lack of a better way of putting it. But it's sort of stalled the progress of anyone's excitement around health information exchange on the dental side for those who even know about it. Again, it comes back to the education issue for us. And yeah, we're still, when we get information requests, record requests, we're still using thumb drives and CDs and printing to get that information across. And so we're hungry for a solution. It's just a coordinated one across the greater healthcare sector.
I wish we'd say that the provider space is different, but dare I say the fax is still a thing that is used. I thought we axed it, but I guess we've moved on to killing the clipboard, which I think is the overlay of what some of the complications in this conversation is as well. And we've seen that from our membership. You know, CMS, it's not quite last year yet, but middle way of this year did announce their new interoperability framework and very publicly stated that they're going to be engaging in trusted exchange, but didn't say the trusted exchange framework and common agreement, and have created this CMS aligned network concept. And there was a lot of confusion, especially from our membership. And I know, many of us on this call have talked separately of like, okay, is this aligned with it? Is it replacing it? Is it the same? What is it? Is CMS becoming a QHIN? And it's clear. I mean, Steve Posnack, the Deputy National Coordinator, just yesterday published a blog post on TEFCA that it seems the administration is still going to continue to support the trusted exchange framework and common agreement. But also we still have these aligned networks kind of hanging out over there, as well as a deregulatory rule that is supposed to have TEFCA pieces in there as it relates to both information blocking and just the trusted exchange framework as a whole. And so that's that other layer of complexity, I think, that's added over a lot of this conversation, is just sort of an uncertain policy space as the administration's kind of ramping up with some of their new data exchange opportunities and policy work.
Yeah, and thanks for raising that, Andrew. I do think that there is some confusion, across the market, across providers in terms of what the CMS aligned network approach is, and how does that intersect, or how does that differ from what the administration is trying to do on the other hand related to TEFCA. So I think kind of sorting that out, reducing the complexities and around that, and kind of managing expectations about where how they coexist together is important. I think some of the other wrinkles that we've talked about, and Rob kind of alluded to this in the intro, relates to HIPAA, and where kind of the differentiation between HIPAA and state privacy laws and information blocking obligations kind of start and stop. So does anyone want to kind of talk about all the other state and federal regulations that kind of impact information sharing, and how how that kind of works with, or in some cases maybe works against what we're trying to do related to information blocking requirements?
Yeah, I can take this. I think the first thing I see a lot of people struggle with is just a standard set of definitions. Like, what is a health information exchange? What is who is an actor? And because we've got different layers of legislation from different years, and so I mean, HIPAA was written pre-internet, really, and so as we've layered on legislation, like the 21st Century Cures Act is addressing through definition things that HIPAA just couldn't because the technologies didn't exist. And so there's the spirit of the law and then the written letter of the rules and regulations. And a lot of people get caught up in definitions. and who these rules apply to, who they don't. Then that's one thing I see states coming in and trying to backfill some of the ambiguity that the federal rules and regulations have left. I'm also seeing, which I'm really happy about, RFIs, requests for informations or requests for interpretations being put forth to these government agencies to get some clarity. Because without the shared common understanding, just like it's a common trusted framework, we also need those core definitions so we're all working with the same understanding of who is responsible for what information can be shared freely, what is restricted health information, these third-party vendors like your Apple Watches and fitness trackers, how does that apply? Like there's still a lot of gray area around who are actors and how, like, what are our rights as patients? What are our responsibilities as patients? What are the rights and responsibilities of actors that may be custodians of patient data? And the bigger question is, who owns it? Like, as Rebekah's alluded to, there's active litigation. The Sequoia Project actually has a website where they're tracking all of the current legislative action and anything that's happening in the courts around health information blocking. And one of the cases, there was a really interesting comment about who actually owned patient data that was kind of surprising. And so those are big questions that need to be answered as we move to this. But there's just so many rules and regulations, federally and state, and then getting into business associate agreements and all of the convoluted mess that comes from just trying to protect patient data and keep it safe, but move what needs to be moved as minimally, like the minimal data that is needed to provide care without interfering. It's a big issue.
I think we'll jump in there too. Is there's lots of confusion, but where there isn't confusion is providers are an actor. And right now, if you look at the complaints, which I'm so happy are public information, the brunt of them, I think there's 1,500, I think 900 or something like that, are all towards providers, right? And they're mostly from patients. And I have to start to say, well, yes, that is true. That is what the regulation says. But when you're not clear and we're getting unclear guidance about the other actors and who qualifies as those actors, how could we file a complaint? We're still in this era of we'll know information blocking when we see it. We know what a health information network is when we see it. And that's really challenging because providers don't know what to do other than say, I can't give you this information in the manner that you want. Will you take a jump drive?
I think, Rebekah, to that point on those 900 complaints and to what you're talking about, it is hard to know. I hate to use the phrase nuisance complaint, but that is where they get, categorically described as what are people that are misinformed on what is an active, legal following the rules, information blocking conversation. I can't do this, but can do that. I can't give you this, but can give you that. And the patient doesn't like that. Does that end up in a complaint? And from a patchwork perspective, we all want a national privacy law. I think Senator Cassidy's released draft text in what is an attempt to get us closer to there. I don't think that has necessarily landed with the thought of this is the solution. And so we're still waiting for Congress to do that. But one place that I think a lot of our members, when it comes to the release and movement, and we've had a lot of conversations with them over the years as it relates to how privacy is protected, is the data segmentation piece of the information release. Someone in the chat has talked about Part 2 laws and state laws. We had the reproductive health care law for a period of time, and several states have their own. I live in Maryland. They are very strict on what can and can't leave the state. And so providers, but also vendors are kind of stuck in this no-win conversation right now, in which what those that were writing the policies knew that the technology necessarily wasn't there. And I think rightfully so, or in the right spirit, we're trying to push us further down the space to say we need to get to data segmentation. But as it relates to actual implementation, it's a big problem when someone says, well, I want this data, but not that data. And the only option you have is to give all or nothing. And it doesn't, that doesn't work when the state law is very different than it is from the federal law. So that's one of the big challenges our members have.
Yeah. Sorry, who did I interrupt? I would just say that I'd echo Andrew's sentiment on a national data privacy law. We hope to see it in our lifetimes. I feel like that's not too much to ask, but it's going to be difficult to get there. We acknowledge that, but absent that, that's the world that we're living in. And there are some states that kind of have, this is how they've described it as New York, from New York, they have upside down consent models. It's opt-in, meaning a patient must give explicit permission for their PHI to be exchanged. So they can't even participate in TEFCA. And when it gets into behavioral health issues, they are just, that is a whole different set of kind of stickiness with them. And there's a lack of education around part 2. And are they hiding behind it, or they think that they're doing the right thing? They just may not have the education on what they should and can't give out. And they may not know exactly how to segment the data either, especially if it's a smaller behavioral health care provider or just someone without the technology that is linked. There's just such limited exceptions for states like that. And if you're a hospital that's treating patients from every state or many states, then it gets to be into very complicated territory.
Alyssa, did you want to weigh in?
Yeah, Chelsea touched on where I was intending to go. It is very, state specific. And if like my HIE, where we can really focus on what's Indiana law and is there any law, state law that might supersede federal law? And if not, we know where to focus. But if you are an organization that crosses state boundaries and there's so much variety in state laws, it would be very complex to have to sort out, when to respond in a particular way because the patient is in this state versus that state, and it can get very complex very easily.
Yeah.
I certainly agree with the complexity. The other thing that I've seen is that we have a long history, several decades of experience with HIPAA. I think stakeholders of both regulations, when they perceive a conflict between HIPAA and information blocking, do I need to protect and keep private this information, or do I need to share this information? And I think if we got into the details, maybe there isn't the conflict, but I think many times stakeholders perceive a conflict, and their long history, the fact that they've seen penalties for HIPAA in the news, that it's been out there longer and has more of that sort of awareness, means that I see that when people perceive a conflict between, am I expected to keep this private and secure, or am I expected to share it, they tend to veer towards keeping it private and secure. That's maybe not accurate, but I think that is a trend that we see as people are trying to comply with 2 different regimes and have, much more familiarity with one than the other.
Yeah, I also
So go ahead, Arna. Sorry.
Oh no, it's also who's initiating the exchange, and that's actually a really difficult question to answer a lot of times. Is this a patient-led directive? Is this a physician-led directive? Is this a request from the person who wants the information? And so we're also missing that a lot of times in these conversations about who is actually requesting and which direction is that information being requested from. But I tend to agree with Sasha that there is a default to protect information at all costs without the understanding, well, now we're trying to get to this place where we want to have the ability to share information freely, but securely. And it's that second caveat that there's just a lack of trust around our ability to do that securely, protecting the patient's information meaningfully.
Yeah. So I'll remind our audience that we want to try to make this interactive. So if folks do have questions, please use the chat. There have been a couple comments in the chat, but if there are other issues that you want to make sure that we address today, please feel free to put your question right into the chat. But moving on, to kind of continue on this compliance discussion. What do folks see in terms of gaps and inconsistencies when we think about technology implementations? Are there things that you're hearing from your members or your stakeholders about those implementations that we may need further action on?
I think for dental, you kind of have to think about it as ambulatory service centers more than physician offices, right? Lots of technology, imaging right there in the chair, various types of imaging available, other tools and things like that. And now we're seeing a wave of new sort of AI products. The problem is that we have an interoperability issue at the chair level, not just at the system or clinic to clinic level. So when we talk about getting all of those records for a patient who's maybe moving and having a transition of care, now we're talking about a lot of effort to get that information out, if it's even possible to get it out. It's not available, and I don't think anybody in any clinic has it at a push of a button, but we have to think about the workflow and the disruption to the office when that happens, and then the cost, because a lot of the tools that are available to providers now do not have a way to do this without special effort. So they will charge extra fees, right? So now the provider can't charge the patient a certain amount of fees, but the vendor may be able to, the software developer may be able to. And so we have a real burden being placed on providers. Not to say that the providers don't want to deliver that information, but it really can add up as we go forward and as we get more tools in the hands of patients to get their information.
And part of oh, sorry, go ahead, Elisa.
From the perspective of the HIE that would fit, I guess, in the vendor category, each state is also different in its requirements for participation in the HIE and data contributions to the HIE. So some states, they have very well-developed rules. Many providers participate and contribute, a specific set of information, and then maybe more than that. In Indiana, we don't have that. And so there are data gaps. And so if in terms of implementations, not only is it, we may not have interfaces implemented with all relevant providers, the data that those members decide to share into the collaborative may be different as well. So if a requester came to us as the HIE expecting to be able to obtain certain information, it may only fulfill part of what they need, and they'd still have to go out to specific providers to get the rest.
I think part of the issue, and Rebekah, you started touching on it as well, is from a technology perspective and a policymaking perspective, some of the issues as it relates to the gaps and inconsistencies in being able to meet the expectations from information blocking and what patients are looking for. It's just that end users are often not at the table, both during the policymaking piece and the technology development. We do lead the Health IT End Users Alliance here at AHIMA, and part of that work that we are doing there is trying to make sure that those that are actively using the technology, whether that be providers or patients or those that are trying to work to move the information, have a chance to both work with the developers and the policymakers to make sure that the goals that we're trying to attain are met with products and processes that are able to fit the way our healthcare system work, instead of trying to have the healthcare system work around the technology. I think a piece of that is really important is that real-world testing. There is requirements within certification for real-world testing, but often a lot of providers see the technology updates And that's not necessarily an issue with the vendor. Often it's the way that the policymaking timelines within regulation work out as well. Our first chance they're getting to see some of this stuff is at implementation. So getting a more either elongated timeline so that more people can have more seats at the table longer, or just a chance for us to really test this technology for its input will really help smooth out some of those issues that we're seeing in information blocking gaps for that data transfer.
Yeah, I agree with Andrew wholeheartedly. And I would say that information sharing, if we're going to call it that, like it isn't failing because of resistance. It's kind of, if it's failing, it's where technology and policy kind of haven't caught up. So if we're talking about like the continuum of care, dentistry included, like longitudinal true care, LT-PAC, it doesn't all fit. They were left out of high-tech funding. They felt like they were finally catching up the LT-PAC space, but with this, it's just sort of like, oh, if the larger provider wants to pay a fee, then you can have access and share the data with some of the LT-PAC providers and the SNFs. And it's just, if you don't have the funds, you're not going to fire nurses or providers. You just don't share the data if you can't afford to.
Right. And I think this comes back to who actually owns that information. Like, as a patient, I feel like it belongs to me. And if I want my doctor or my specialist or somebody to have access to my medical records, like I kind of have an expectation that that can get across to them. Melissa Swanfelt in the chat raised a really good point, which is there's a lack of national standards related to consent. And I agree. A big part of this conversation is if a patient consents, like what's stopping the information from being shared? Like it's in everybody's best interest to get it across. And so I appreciate that wholeheartedly. I 100%, 110% agree that we need to be having those conversations at a federal level.
I think one of the things that's been a challenge for us as health IT developers, and this maybe goes to Andrew's point about timelines, and the relationship between policy and technology. I know all of us involve end users in our design and development processes, but there's been a real disconnect between some of the policy required features and the actual needs of information blocking compliance. Some of the policy required features, EHI export being one example, have been huge development projects that have seen minimal use and gotten feedback from stakeholders, patients, et cetera, that they're not really meeting their needs, but they're required in the certification process. And things that I think people are more interested in to further information sharing have had to move lower on the list because certification has put out things that everyone has to meet to participate in that program. And so I think the more we can, to Andrew's point, get that feedback about what is really valuable and what's not valuable into the policymaking approach, it'll allow for that to be much better prioritized.
And if I can just add in, we've got to stop tying all of our technology policy to certification. There's huge chunks of the healthcare system that do not use certified health information technology. I want to be very clear. I think patients should get their information, and I want providers to be able to give it to them. But if I'm a provider and I don't use certified health information technology, I'm on the hook, but none of my technology is. What am I supposed to do? All it's doing is actually harming my relationship with my patient. And if I'm a patient advocate looking at this, and I go in on a Monday and have a whole bunch of x-rays that cost, if I have insurance, $300, $400, and it will be covered. And then I go see the specialist on Wednesday, and now I need a whole new set of x-rays, and they're not covered, and I have to pay out of pocket. Well, guess what? They're not going to go in until that tooth has to come out, and they're going to go to the emergency room to do it. This is a real impact of some of the challenges that we're facing. Information blocking, I think, we're talking about the right concepts, but I don't know if the execution is there yet.
I agree. It's a challenge that the information blocking actors are only certified health IT developers. It kind of creates an uneven footing in the health IT space.
No, all great points. Why don't we kind of jump ahead and kind of to our next section and talk about the exceptions and education and outreach opportunities. So, we do have a kind of clearly defined set of exceptions at the moment, but I would really love for folks to kind of weigh in on which exceptions are you hearing from your stakeholders are most misapplied or kind of misunderstood? Who'd like to start?
I'm just going to say yes and then pass.
Right. Yeah. No. I was going to say you're not allowed to say all of the above. So Arna, you have the floor.
Well, I think the entire premise of information blocking is misunderstood. Where we really struggle is who is an actor and what are their responsibilities. I would say that's probably top of mind for me. And yeah, we've spoken about it a lot already.
Even as an expert, I have to say, as we went, it's been shaking the cobwebs loose on some of this to do the session alone and thinking like, oh yeah, I completely forgot about those exceptions as we were prepping for this. I mean, I think there's still so many questions around things like infeasibility, performance, even how the handoff for content and manner goes. I think a lot of it is just understanding the nuances. At the end of the day, I think someone said, is information blocking just going to be something that we kind of know it when we see it to move forward? It's also a question on these exceptions of, well, when do you get to invoke them? Like, is it something where you're on the phone and the patient's like, well, I want this, and you're like, content and manner, we're going to do blank, 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 and do this, or can you work on it after the fact? And that's, I think, where a lot of the questions that we have, but they are, for us, they kind of make sense in points like, yeah, of course, infeasibility is a developer conversation that you're having with it. But when you're talking to someone on the ground, they're like, well, no, I go into the system and it just won't let me do that. That's infeasible. And no, that's not really what that's talking about there. And I think just it's going to be a little bumpy, I think, as we kind of see the first set of investigations and penalties to see what exactly these look like.
Go ahead.
Sorry, who am I interrupting? Again, I think it's just really quickly, like, we can't expect our clinicians or frontline staff or any of them to be attorneys. They are generally not, and their job is treating care. That is their core mission. That is our members' core mission. They, fortunately, most of them have, chief compliance officers, chief privacy officers, but your smaller providers don't have that. The doctor is often chief compliance officer, chief privacy officer, and the burden is very significant. And I think everyone's just like, fingers crossed I'm doing this right, without knowing for sure that they are doing it right. But I know from our members' perspective, they are risk averse. They err on putting everything they possibly can as soon as they possibly can into their patient's portal, patient my chart, whatever they have. All of it just goes rapid fire. As soon as they have it, it goes. So I've seen, misspellings in my own and just all sorts of, because they just want to not be accused of holding back information. And it is their patient's data. They believe that it belongs to them and they want to do the right thing. But sometimes it just is difficult for the smaller providers and the rural providers, especially if you don't have broadband. It's not really going to be a quick upload.
Yeah, I think risk averse is the right way to look at the exceptions, because I've had a couple of conversations with folks who are listening on the line, and they'll hear my talking points. Document everything, just as if it was your clinical documentation justifying treatment. Justify why you weren't able to give the information. Write everything down. And I hate that answer. I really do, but I can't expect a clinician to understand every exception and which one it fits into. So it's kind of like document it. So if a complaint comes in, you're going to have the answers and the information that you need to defend your practice, honestly. Because, I mean, with some of the possible fines that we're talking about, we are talking about seeing the practice go under. And then that's access to care, right? That's not the intent here.
Yeah. No, I think that's a good point to kind of hit home, Rebekah. I think that dental practices are in a lot of cases in the same situation as small physician provider practices in terms of kind of how onerous a lot of these requirements are, but also in terms of some of the disincentives that we're looking at down the road. And the other thing that I want to emphasize to kind of hit home what Andrew was talking about is we really are functioning in kind of an information vacuum for the time being. We did have the announcement in early September from HHS kind of talking about a crackdown on information blocking that I think caught a lot of folks by surprise to a certain extent. I mean, it does fit in with, I think, the larger agenda that the administration has really tried to be patient focused and make sure that patients are empowered with control over their own information. And so it fits in I think in that way. However, I do kind of worry that we are all these issues and complexities that we've discussed on this call, for the past, actually 56 minutes, really kind of come into play here, that folks are a little unsure about how to meet all the expectations that are out there related to information sharing and can suffer like pretty dire consequences if they do not have, the kind of information available to be shared and accessible to be shared. Does anybody else want to talk about the exceptions and where they're kind of misunderstood or misapplied?
Well, I'll give the one that EHRA came up with in our discussion because it hasn't been listed so far, and that was the manner exception. This was added after the original proposed rule, so I think we got a little bit less insight into how it was expected to work and discussion about it as an industry. And we saw, the industry saw earlier this year that the manner exception was discussed in some state level court cases. And EHRA, in looking at those court cases, felt like there was some significant misunderstandings of the intention of the manner exception and how it would actually work in practice. I think that speaks to the complexity of it. One thing that it caused EHRA to do is we started a blog series on all of the exceptions, trying to make sure that we could educate our members and other stakeholders who were interested in, how would you start to understand these exceptions, especially if you maybe have not been involved in the industry discussion to date and are trying to kind of get up to speed on some of those pieces, because it is quite a complex set of requirements.
No, highly recommend your blog series, Sasha. I think those are very helpful in kind of understanding the kind of developer perspective on everything. So kind of turning this around a little bit and talking, I want to try to hone in on the point around how even in kind of this uncertainty around a lot of the exceptions and expectations around information sharing, how should we think about kind of internal training for clinicians and office staff and other folks as we kind of think about figuring out where to apply the exceptions and how to fulfill the wishes of patients or partner organizations in terms of sharing? Who'd like to start?
Well, I would say for my organization, I think the best way for me to educate them would be to identify when to escalate to me so that I can handle it. because I don't expect them to really figure out the finer points. If they have a scenario that fits particular criteria, they just send it my way and not worry about it anymore.
I echo what Rebekah had said earlier. Document everything. Try to be as consistent as possible, but without, giving like legal advice. It's really a gray area. And unfortunately, I think without sort of any OIG advisory opinions or anything that is a true legal protection for folks, we're just like on pins and needles, like all of our fingers and toes crossed, just waiting, hoping we're doing the right thing. And unfortunately, we won't know until some sort of enforcement action comes down, and it is on whomever. But if it's going to be on, like, for example, like a smaller provider, a smaller behavioral health provider who thought they were doing the right thing all along and keeping their patients' information private, then they will no longer be able to practice. They will shutter.
Yeah, and that's kind of the hard place that we're at. Like, I can't give legal advice to any of my members or to a dentist individually. So what I do is I share the resources that get shared out on information blocking and say, hey, here's this. Or we even had, back when it was still just the ONC, and the ONC present a webinar about it, but they can't really tailor it to the dental audience because the rule is the rule. They don't have a cutout or carve out. And I don't think we need one, but practical guidance would be great. I would love to see more information. I think we've talked about maybe personas or SOPs for offices, best practices, that sort of thing. Those are the tools that we really need to get into the hands of providers.
I think we heard at the beginning of some of the work that organizations were doing to get ready is they were pulling together councils within their organizations, just thinking from an HI perspective, they're getting their chief of AI, their chief information officer, maybe their chief privacy officer, trying to get everybody at a table to try to talk through what this looks like. How do we make sure that everybody is on their toes and ready to go? Where does all of our information live? And I think there was a bit of a wane in some of those councils. I've heard that people still have them together, but I've heard they've started to get kind of revved back up again now. And that way they'll be able to better understand what happens when an information blocking complaint comes in. If they do get faced with an investigation, someone starts asking about them, or just there are changes to the rules, it allows them to have these kind of active tabletop conversations in real time as they want to try to navigate what the new space is. And I think we all talk about information blocking as it's sort of this black and white, although I think we've made it very clear that it's very gray today. But so much of the rule is grounded in intent, that having those kind of groups that are working together to make sure that they are demonstrating that they are working to share the information as best as they can or as best as they understand the rules, that's going to go a long way if they ever are confronted with an investigation, just showing that intent that we are trying to share.
Yeah, I want to actually take what you've said, Andrew, and sort of expand it a lot. So we need governance is what it comes down to. But governance doesn't have to be bureaucratic. Like, it can be 3 people. It can be a clinical leader, an ops or an IT person, and a privacy security person that just have a cadence of coming together. And so when we think about training, the first thing we really need to think about is looking at the legislation and understanding what applies. And then as you also said, tabletopping, like coming against scenarios and saying, okay, we've got this patient here. They have sensitive mental health information in their record, and there's been a request for information. Or we are a gynecological provider and we need to exchange information, but some of this cannot go out. And actually just sit down with practical real life examples that apply to your scope of practice. And when you come against something that doesn't make sense or you don't have an answer, put the burden back on the regulatory body through the request for information or request for interpretation to come forth with an answer. We've got a lot of potholes here. And again, if we look at legislation as infrastructure, it's not built all the way out for high speed exchange. And we're going to have to identify, and this is going to be a slow and steady. It's like a search party when we've got a missing kid in the woods. Like we have to just sort of walk our way through and cover all ground. And when we come across something that we can't answer, actually go and ask for clarification. And so it's not a sexy answer, but we have to do the work, and we can't just leave it at associations. Like this will take a monumental effort on everyone's part. But if we all sort of understand that we're all in this together and we can all come, and it doesn't have to be monumental, but we have to all look at this and identify where can we help, and then start educating from that point, I think will be really useful for the industry.
Yeah, Arna, what I'm hearing is we all agree we should be sharing information, but without having to go, on back roads that are not there anymore and are washed out, or, if we just can't comply confidently in a vacuum of guidance. And
Yes.
without even the frequently asked questions getting updated in the past 2 years.
I know.
That would be nice.
And we
It
can't
may be
guess.
helpful.
Yeah.
No.
And that's why I'm just like, let's put it back on. I mean, and I get pretty elevated here, but I'm like, if you're going to put this legislation out, it's obviously a skeleton. We need to build out the rest of the system. So let's all come in and I say, okay, we need more clarity here. We need more clarity here. But our responsibility on the provider side is to recognize where the gaps are and put that in front of whoever needs to make those decisions and say, we need an answer. And we can help solve it, but we're not going to take sole responsibility for interpreting the law here. We're going to do it together.
Yeah. Now, I think you all did a great job compiling everything. And the issue that I will just add, and something that I think that we have asked for in kind of multiple venues, is like the advisory opinion authority for ASTP or for HHS OIG. There's a lot of a track record in terms of other compliance programs when they are first kind of put into place, that the idea of an advisory opinion structure also comes along with it. There are a lot of questions about whether ASTP has that authority, but I do think that would be helpful in kind of figuring out and answering a lot of these questions. Something that is like Arna was saying, in terms of like a real life scenario, in terms of what we're encountering in trying to share a particular piece of data with a partner. How, if I cannot do that, is it information blocking? Is there another means that I should think about in terms of how to get that information kind of across the transom to share it with the patient or again with a partner? So that's just something that I think that we will continue to ask for, and that I think brings to bear when we're thinking about and as I raised earlier, the idea of this new kind of crackdown on information blocking, and ASTP's enforcement posture. What steps are you all recommending that your members, your stakeholders, kind of take to kind of prepare for that kind of new enforcement posture that HHS is continuing to kind of tout?
Well, this isn't new, Jeff, but one thing we've tried to do for our members at EHRA is we developed good information sharing practices. One of the challenges is I think that information blocking is in some sense what you shouldn't do, but it's much easier for people to formulate a compliance program around what you should do than, sort of avoiding doing certain things. So by putting together good information sharing practices, which we published for our members or for any other stakeholders that may not be EHRA members, we tried to identify, how do you support interoperability, information sharing, patient access, um, participation in trusted networks, and so forth, all these things that are important. What does that look like from the perspective of an electronic health records developer, to try to help members say, like, hey, these are good things to be doing that we recognize demonstrate your intent to facilitate interoperability and access, as part of sort of your responsibility in the ecosystem.
Yep, great point, Sasha.
I think for us, it's hard. Besides the things that we've kind of practically said, this is how you start preparing for it. I think the issue that we're going to have is until we see what the complaint process is and what the options for remediation are, it's kind of hard to prepare. I would hate to see, if there's a complaint against a provider who didn't uh, give out the information because their technology just didn't support the option, being told, well, you have 3 months to get on a software that does. Again, that's not we need to QI this before we start really having really tangible disincentives for providers. Figure out what will work to move the needle towards removing the information blocking barriers so that we don't need the exceptions, but let's not come out and swing a bat at our care delivery system either.
Rebekah, even if you asked a larger provider if they could roll anything out in 3 months, I think they would laugh. That's just not happening. So that expectation should just be null and void across the board.
And I did not mean to say that I had heard anything about 3 months. That was
we just made up hypothetical 90 days.
Like,
but we can't do that in 90. Even if we had the money to do, it takes time to implement the technology and processes and workflows that follow, and then work out the bugs and kinks. Yeah.
Yeah.
I think one of the most practical steps as we're thinking about this too is like, just don't panic on this from like a provider or a developer. Like, I know that there's this crackdown or like they're re-emphasizing it, but like nothing's changed. Like, we've all been required by law to do these things for several years at this point. And to Sasha's point, continue the best practices that you're doing to share the data, keep those communication lines that you're having open, and just, if you are as an organization that has been working to share data as readily available as you can and have been working in the patient's best interests and trying to follow the rules, you're most likely, we can't say for certain, going to be able to navigate this space and come out on the other side. Okay, I'm not saying that they're not going to have potential penalties or things like that, but you're equipped and ready to deal with what it may be coming. I mean, it's still so strange, as you mentioned, Rebekah, and because we can't really, there's the $1 million fine as it relates to HIEs, HINs, and the vendor developer community, and the provider community. It's still kind of like, there'll be penalties. Where will they be? It's kind of unclear. And so you've just got to have trust in the governance and the oversight that you've put in place within your organizations. And if you don't trust it, pressure test it and find out where you do have those gaps and work internally to try to fill those.
And back to the thing we keep saying, have standard operating procedures and document your progress. Just it's good to demonstrate that you are working towards something, but it's also good learning. You can look back and having the habit of documenting what you're working on will only set you up for success. And once we know more, we'll adjust and pivot. But until we have more information, that's the best we can do, is just write it down and keep a log, and where you can, keep audit trails, and have really good relationships with your technology vendors, and start to get loud about the features that actually are necessary for your aspect of compliance in wherever you sit, because we've got a lot of representation here, but I tend to have a very provider specific lens. You have a say, like, you are paying for this technology, like you have a say in how things get developed. You just have to use that voice.
So how do folks think that we can collaborate better? And I think using the royal, I'm thinking about us as organizations that represent all the regulated actors. Um, uh, what sort of opportunities are there for us to kind of collaborate better? And I think WEDI bringing us together today is a good example of how we can all share our concerns about the complexities around information sharing. But what other ideas do folks have in terms of things that we can be doing to collaborate better?
I will go out on a little bit of a limb here and say that if there was some sub-regulatory guidance that helped providers feel stronger in their ability to extend their instance of their EHR and share with lesser resourced folks without bearing all of the liability, they would be eager and happy to do so, especially where it makes sense in their regions to connect to other folks. Like in the continuum of care. It's about the continuum of care. And I think that if there was some sub-regulatory guidance that made them feel their legal teams feel a little bit more comfortable about that, then they would absolutely be willing to do that.
Don't be afraid to engage in open dialogue. I know, at least myself, right? Chelsea, you and I have talked several times about some of these issues. Sasha, we've met with you and your colleagues at EPA. I've done the same with Hans and Josh over at Oracle. It's okay to admit that you might not know something. I know that's hard in this space of knowledge growth to know that, to admit that. But a lot of finding out issues and errors and changes is just through saying, like, I'm having these questions, or I'm having members that have these questions, and I just don't know the answer. What do you all think? Have you experienced it? How are you managing it? I mean, just that open dialogue is what's going to help the most. And sometimes it's hard in this space, especially because we all do represent at times different stakeholders in this conversation.
And competing priorities.
And that includes the government too. Don't be afraid to reach out to ASTP and CMS and be like, I don't understand this, or this doesn't make sense, or we need clarity, or there's they will answer.
Please do that. Like, don't be afraid. Please do it. That's what we need. I see Leslie raised her hand before we go over that way. Much like we have some infrastructure through like HL7 connectathons and different groups. So we also have like one thing that keeps coming to mind for me is like the Health Sector Cybersecurity Council. Like actually they came together as an industry government group to come up with best practices. And it's just finding like-minded peers that are also taking on this problem. And to your point, Andrew, just having the vulnerability, I suppose, to say, look, we can't all know everything, but collectively we can come pretty close to solving this. And it's just understanding where we can chip in and help or bring our subject matter expertise. And we need to identify knowledge gaps, bring them to the surface, and then work through them through industry groups, connectathons, engaging the federal government, and keep walking in that direction. It's going to be a team effort here. This is a team sport. It's not an individual exercise, and one person can't, or one association can't solve this.
Yeah.
And I think I would add to, and prioritization is a good answer. The next 5 years, if you look at what's on the health information technology docket of what we know about and then what may be coming in the future, we have a lot of work. Like this is not just one small bite of an apple. You have 15 apples coming at you and you have to eat them all. So I think the more we communicate, not only about why it's important some of these rules are coming down and some of these regulations are in place, but how challenging it can be just to meet the basic sort of intent of some of those rules. And I think information blocking is a really good example of just like, yes, it's not new, but clearly we have some issues that we have to address, and we can't let that drop to the background just because there's another apple coming down towards your face.
Leslie, I see that you have your hand raised. Michael, I'm not sure if we can unmute her or.
Can you hear me now?
Oh, we can.
Awesome. Thanks, Jeff. First, thanks to all of you. It's so important to have these kinds of discussions. And I just wanted to say there are many times that you've all spoken, particularly about good information sharing practices. And of course, because of my perspective of having worked in the HIPAA implementation side of the house for so many years, I think we have a lot of synergies and lessons learned. I know that not all of the actors are also subject to HIPAA, but the whole, hey, here is how you're supposed to share on the federal level, treatment payment operations, we've got years of understanding how that works well, even though we have plenty of problems also. And I just think that possibly some way for us to compare and contrast information sharing practices, good information sharing practices under information blocking as compared to HIPAA might be helpful for people. I don't know for sure, but I think it would be. And the other thing is, remember, every time we do this, whether working with a small provider or whomever it is, somebody mentioned we're still doing things by fax. We still have people that don't do a complete risk analysis under HIPAA security from 2005. So we're constantly going back and trying to explain this stuff, and yet every one of our rules gets more and more complex, it seems, to work through. So I just kind of wanted to call that out. I think that might be a deliverable for us somehow across WEDI to come up with some way to explain and contrast and compare, and then grab those lessons learned so that we can help our industry implement.
Yeah, Leslie, I think very good points. I think that there is, since again, and I'll use the term kind of information vacuum as we wait for that first kind of enforcement action. Folks are I think are in a wait and see posture in terms of how to do that, and maybe don't want to necessarily go out on a limb with a kind of legal opinion related to how that can happen. But I do think that again, folks can talk about best practices or about how they're approaching something in kind of a I would say like a non-binding way. That sort of like discourse and discussion I think is very helpful as we all try to figure out which way to go. And again, maybe that's WEDI is such a great convener. Maybe that's a way for WEDI to kind of help bring folks together and share their best practices, but not do it in such a way that we need to bring in an army of attorneys. Nothing against attorneys, but an army of attorneys to kind of interpret and everything that we're discussing.
Mm-hmm. Implementation focused.
Yeah. So I know we just have a couple of minutes left. I did see that Michelle put a question in the chat. For those folks that can't read it, has anyone had any luck reaching out to ASTP CMS on something to getting them to interpret and get a clear answer from them? And Michelle stated that in their experience, they the federal agencies kind of restate exactly what is in the ruling with no additional information or in kind of interpretation of whether their kind of question or way of doing thing is necessarily correct or not. So since Chelsea, I saw that you kind of answered that.
Someone
Do you
tell me
want-
if I'm wrong, though, if that is Andrew, I know you'll tell me if I'm wrong, but I think that is, they respond to me the same way. I think it has to do with they've asked, to their credit, they've asked for the ability. It needs an act of Congress for them to issue advisory opinions, but they cannot right now. So that is, they're doing what they can, and that's about it. It's sometimes not helpful and frustrating.
Yeah.
I've had mixed success. For me, the formula that's been the most helpful is I'm asking for a very specific clarification on X, and the reasoning behind this is Y, and what an answer looks like is Z. And again, they do normally cite what already exists, but that has been the most helpful formula. It's very brief and succinct, but just spelling out exactly what you want from them and giving them the context that might be helpful for them to answer. Because again, it's a human interpreting something that we are subject matter experts on, that to us the context is obvious, but it may not be to the person on the other end of the line. I know that's not always the case, but where they can expand, that's been the best formula.
No, good points. Thanks, Chelsea and Arna. So we just have a couple minutes left. I want to try to end on a kind of positive framing of this. So how do we turn information blocking compliance into kind of a value add for interoperability for patient access? Again, kind of reinforcing some of the themes that we're hearing from the administration. I think when you think about things in kind of a value add context, at least I'm operating from a positive perspective. So who wants to weigh in on that question?
I would say if we continue to align privacy, interoperability, and sustainability, and avoid sort of the forced trade-offs that'll undermine patient trust, the long-term value is there. Easier said than done.
Yeah, and I think here it's centering around the patient experience, right? The patient is asking for their data for their personal use. And whether that's through them asking directly, through having a third-party application ask for it, transferring care, it doesn't really matter. It's about that, right? And I just go back to the amount of waste and harm that can be avoided if we turn information blocking into information enablement or something like that, right? We can make sure people are getting the right treatment at the right place. That's the whole goal here. And I think so when we talk about information blocking, I tend to talk about the big scary issues and problems with it, but I'm like, how great would it be in this other world where this isn't an issue and our patients can get whatever they need, or me as a patient can get the things that I need.
I guess I have a really unique perspective, having lived and worked in 3 different countries in the healthcare delivery system, and only one of them struggles as much as we do. And so I've seen the promise of what instantaneous access and freely shared health information can do from a patient perspective, from a provider perspective. And I mean, it's no secret that America is exorbitantly expensive to navigate as a patient. And a good portion, Rebekah alluded to it, is the amount of retreatments and the amount of things that we are just we're putting the economic burden on patients and providers to deliver this care that has already been delivered, but we can't see it. And so where the value add is if we have access to these medical records and this health information, we're saving time, we're saving money, the outcomes are better, we're saving lives. Let's just put it down there. Like, patients will live longer. We won't, because we're able to coordinate and collaborate with our peers to make sure that we're getting the care that patients need. Like the amount of lab tests and imaging and all of these things that we continually reorder because we don't have a record of it. And physicians need that burden of proof to be able to go down the track of care. Like I get that. But it's expensive, it's a waste. And so the patient experience here will be so much better. And frankly, we need to do whatever we can to reduce costs because it's becoming untenable in this country to access care for every American, not just our disenfranchised neighbors. Like it's getting to the point where we need to have a really serious reckoning about what it is we're trying to do. And we need to keep that message and spirit as part of these conversations. Like we need to be doing this for the patients. And it's an economic and a patient safety conversation all the way around.
Awesome. I think that summed everything up so nicely, Arna. Thank you. Thanks to the panel. I think really appreciate the great discussion that we had today. Michael, I'm going to turn it back to you for kind of some concluding remarks. But thanks, everyone.
And thank you, Jeff.
Yes, definitely.
Yeah.
Thank you, Jeff. Thank you, Chelsea, Rebekah, Sasha, Lisa, Andrew, Arna. I'd like to hand it off to our Executive Director, Rob Tennant, with some information about upcoming WEDI events and a work group.
Yeah, and let me add my thanks. A phenomenal discussion, Jeff, masterful moderation. But the conversation does not end. We've got a lot of education here coming up in the next little while. December 9th, we got the Blue Cross and Blue Shield of Alabama's path to CMS 0057 prior authorization compliance, sponsored by iTility Health. For WEDI members, we have two events. On the 10th, we have the annual membership meeting at 1, and then at 2, we'll have our privacy and security work group lead a discussion on changes to HIPAA Part 2 for substance abuse order consent. So you won't want to miss that. And then a very interesting program offered by Edifex, how Care Oregon solved prior authorization complexity without breaking the bank. So with that, again, I want to thank Jeff and the panelists, and thank you all for attending, and we look forward to seeing you at future WEDI events. Thanks so much.